Welcome to Endoscopy Now and today's presentation on the role of GI endoscopy in surgery, sponsored by AMBU. I'm Hannah Vassar, and I'll be introducing today's session. We are pleased to introduce today's speaker, Dr. Reginald Bell. Dr. Bell will be presenting on the role of GI endoscopy in surgery. Dr. Bell is a surgeon in Denver, Colorado, specializing in benign foregut surgery. He is a board certified general surgeon and fellow of the American College of Surgeons. Dr. Bell is a founding member, chairman of the board, and president-elect of the American Foregut Society, a multidisciplinary society forging relationships between medical and surgical experts to improve patient care. While in private practice, Dr. Bell has also worked with leading academicians and has published original research on novel procedures to treat foregut disease. Welcome and thank you for taking the time to join us today. And with that, the floor is yours, Dr. Bell.
Well, thanks, Hannah, for the introduction, and welcome to all of you kind enough to join us today. As Hannah mentioned, I've been in practice now for 31 years, and I've performed flexible endoscopy as an integral part of that practice since the beginning. I'd like to kind of share with you my perspective that I've gained over that time regarding how flexible endoscopy is really an integral part of my surgical practice. Right now, my practice is 95+% foregut disease, so that's really primarily what I'm going to be talking about. I'd like to thank Endoscopy Now for inviting me to be part of this, as well as AMBU for their sponsorship, and both for their collaboration with the American Foregut Society, with which I'm deeply involved. So these are my disclosures. Probably the most important one is I really like to operate. It's just been a wonderful career to have. Like all humans, we're all humans and we're all subject to tunnel vision. And kind of as we develop our specialties within medicine, we become more and more like the blind men describing the elephant. And surgeons and gastroenterologists pay attention to different things, including different things during an endoscopy. GIs tend to focus on mucosal disease, surgeons on structural anatomy. And so I'm going to try to illustrate for both of you what, as a surgeon, I tend to focus on and have learned from flexible endoscopy. So why should surgeons do upper endoscopy? Well, I'm going to talk about the value of performing endoscopy during foregut procedures and building up skills to manage postoperative issues, its role in preoperative planning, and hopefully encourage surgeons who don't do flexible endoscopy to start adding it to their foregut practice, and then building up skill sets for the future, because the future of foregut disease is going to hinge intimately with endoscopy and its innovations. So what are the potential barriers to surgeons performing endoscopy? In other words, why isn't everyone doing it? Well, like it or not, and although it's changing very rapidly, there are still places where there are turf wars. And I encourage surgeons to recognize that ultimately, I think their GI colleagues are thinking about the safety of their patients and the skill set needed to do endoscopy, because that's what they do. And I think as a surgeon, I would feel the same way if some other person came up and said, hey, I want to start doing laparoscopy. It's not so much that I'd be concerned about turf as it is, are they really competent to do it? So use your relationship with your GIs to observe, brush up, talk to them about how they're doing things, and maybe request the GI to come into your operating room and do an intraoperative endoscopy so that they can see what you're doing, what you're looking for. And that'll, I think, make it clear that you're not looking to compete for their patient care. You're looking for something really pretty different. Now, one of the other barriers to surgeons performing endoscopy can be credentialing. And there are credentialing standards set by GI societies such as ASGE, and I'm a member of ASGE, and I support greatly what they do. However, the GI societies have oftentimes come up with a minimum number of procedures to be performed before competency can be assumed. And in this GI endoscopy publication, it's recognized that the quality of evidence for this number is not really very good. I'd like to compare that to surgical societies, especially SAGES, Society of American GI Endoscopic Surgeons, And what they've noticed is that efficiency in endoscopy increases with experience, but quality measures and complication rates are not always related to specialty, experience, or case volume. And they think that skills assessment really should be done using a validated tool to develop criteria to establish eligibility for credentialing. And also, the credentials for intraoperative endoscopy should be included as part of the index surgical procedure. And part of their challenge to the number of cases to be performed is this is just a graph showing the different colors or potential different physicians with a skill acquisition. And some people will acquire a skill with very few number of procedures. Others will require more than the number of procedures considered before they become even barely adequate at the skills. And I just remind people that I don't say this to patients all that often, but 50% of all doctors graduated in the bottom half of their medical school class. So not everyone's the same. So we really need to develop validated tools for this. So how do you go about getting credentialed? Well, first off, start by addressing any turf war issues and let your GI colleagues, if they're concerned about it, let them know you're not competing for their patient care. And then go before the credentials committee. Cite SAGES and the American Board of Surgery also have guidelines stating that flexible endoscopy should be part of a general surgeon skill set. And tell them that really what you're interested in is performing intraoperative endoscopy when it's integral to, in my case, foregut procedures, and that that's really your starting point. Now, having said that, there's another barrier to surgeons performing endoscopy frequently, and that's equipment. Capital equipment costs money. And especially if it's not used in a day in, day out situation compared to GI labs where a scope may be used 20 or 30 times a day. And especially if there are multiple types of scopes used. So this may be beyond your OR's budget for the volume that you would be using it. There are routine maintenance costs to it and reprocessing, especially if you want to bring additional sterilization equipment into the operating room, or you send it back to the GI lab where it gets lost, of course. And then scheduling, tying up a GI lab scope in the operating room for 1 to 2 hours is a significant cost to the hospital and potentially a cost to your GI colleagues in the hospital using the GI lab. And then there's the OR staff knowledge base. The OR nurses haven't been trained on setting up equipment. They don't know what to do with those little darn buttons. Half the time they don't push them in all the way into the scope. Where do you put the darn scope in a crowded operating room so that you as a surgeon can see the screen? And there's increased maintenance cost breakage because of lack of familiarity with fragile equipment. And we certainly had that in the first probably 2 to 5 years in our operating room when we started bringing that equipment into our OR. So to me, one of the potential solutions that I think is going to be coming up pretty soon is the single-use endoscope. And I think it has great potential in the operating room for a number of reasons. One is that annual costs of reusable scopes are dependent upon volume. High volume centers, they can make reusable scopes very cost effective, but in low volume centers, it becomes far less cost effective. Companies making single-use scopes know they need to be competitive on cost, and part of their edge there is in the lower volume centers. Low capital outlay for the processor and video unit because they're state-of-the-art ones instead of ones that look like they were the same as 20 years ago, you know what I'm talking about, makes lower volume use economically feasible. Some of the companies are developing modular systems so you can have the same handle for various types of scopes, which decreases R&D. And new technology decreases the need for space. These new units can be often the size of a big laptop, maybe a little bit bigger. Scheduling conflicts are reduced because it's now in the operating room. Maintenance is essentially eliminated. Sterilization equipment and those setups are eliminated. Simplicity of setup is much greater. And there's also, and this is something we often forget, there's consistent image quality and quality of ability to do a good retroflex view. And on the right here, you see an image that I had today using a standard reusable flexible endoscope. I couldn't get it retroflexed all the way. And you can see it's a pretty dim image. So the cables are loosening, and the light cables, the fiber optic light cables, have been damaged by multiple bangs. That's the kind of maintenance that we often forget about. So I think down the road, these single use scopes are going to find a significant role in here. The other way to help encourage use in the operating room is to talk to your colleagues, or maybe you're a GI surgeon who does a lot of other stuff, but it has a significant use in acute care surgery, both in the ICU and doing PEGs. Colorectal surgeons can use it for leak tests and for polyp location, bariatric surgeons, and then depending upon modularity of the system, the same processor could potentially be used for bronchoscopes, et cetera. So think about that multi-service use. And if you want to start doing endoscopy, what's the best place to do it? Well, in my experience, it was in the operating room. I started by doing it intraoperatively, and I'll talk about some of these reasons to do it. But mostly it was to build up my skills to prepare me to take over, believe it or not, some postoperative care. And there's a reason that I think it's important for a foregut surgeon to be doing at least a lion's share of their postoperative care. After I started doing it intraoperatively, I do it postoperatively, primarily for acute postoperative dysphagia. And then preoperatively, as my practice grew and I became really a specialty kind of practice, and we started getting a number of referrals from outside of our regular network, patients would find us on the web or personal referrals or whatever. I found that really we could offer kind of one-stop shopping, and that involved me doing my own endoscopy. And it really was pure preoperative work. I wasn't doing it for any other reason than patients were interested in surgery. Especially when it came to redo surgery, I've learned that a barium swallow can miss a herniated fundoplication, and I needed to take a look myself before recommending a reoperation. And then, although it's changing, fortunately, for the better, as more and more GI practices are doing wireless pH testing, when I started doing this, my GI colleagues weren't interested in doing Bravo pH testing because it was just not cost effective for them. And so I started doing it myself. And to do that properly, you really need to do an upper endoscopy. So some of you surgeons out there may be saying, that's all nice and good, Dr. Bell, but why should I bother? I get good results without it. And I think a really simple answer is every high volume foregut surgeon that I know performs routine intraoperative endoscopy. And there's a reason that they do it. And I'll try to illustrate that to you. But it's not good results, it's great results that we're aiming for. We're doing reconstructive procedures in foregut surgery as opposed to a lot of other general surgery that's extirpative surgery. And so you really want to know how to do it great. So intraoperatively with anti-reflux surgery, after mobilization, we want to know esophageal length and the location of the esophagogastric junction. I also find that I want to make sure I calibrate my hiatal repair precisely. And then at the time that I create a fundoplication, I want to make sure that it's not kinked or twisted. Now, over the years, I've learned there's a unique opportunity I have as a surgeon, and that is I can observe for the only time in a person's life when there is complete dissociation of the esophagus from the diaphragmatic crura and from the phrenoesophageal membrane. And you're probably saying, what are you talking about here? What difference does that make? Well, there's a concept that was sort of brought about by Tom DeMeester and Parrot Chandrasoma some years ago, called the dilated distal esophagus. And historically, we have called this the cardia of the stomach. And in fact, there's this classic Frank Netter diagram of human anatomy showing the gastric cardia. Unfortunately, this is not normal anatomy. The cardia, to me, is a term that should only refer to the distal esophagus that has been damaged due to hiatal hernia. And for those of you that do flexible endoscopy routinely, I think you'd probably agree with me. Patients who have no hiatal hernia do not have a cardia. the squamocolumnar junction, is always at the end of the tubular esophagus and can frequently be observed on a retroflex view. So the cardia is actually damaged esophagus. And it's damaged esophagus because of the distension created by, um, by the hernia coming up and sort of deforming the angle of His and then allowing the pressures from the stomach to distend the distal esophagus. And storage organs have rugal folds. So long-standing hiatal hernia damages and widens the LES, and it results in this dilated distal esophagus that has rugal folds that we have called the cardia historically. Now, the end of the tubular esophagus, in my experience, corresponds always to the angle of His. Once you've dissociated everything and you put a scope down and you say, where is the end of the tube? It's always at the angle of His. And that's important to know because if you put a lynx or a fundoplication just above the angle of His, which is where it ought to be, it still could be below the start of the rugal folds and could appear as a slipped Nissen to the physician who doesn't know what happened at the time of surgery. They know what they're looking at, but they don't know what that represents because they weren't there at surgery. And so this to me is to maybe help you understand what I'm talking about. In the normal anatomy, we have the esophagus that ends just below the diaphragm, and the angle of His, sort of that pinch, is a combined pinch of the sort of pinch of the distal esophageal sphincter, which is kind of the crural fibers, and the diaphragm. Patients who have a hiatal hernia have a separation of the two, so there's a pinch here where the distal esophagus is, and then there's the pinch of the diaphragm. But really, the only way that you can know that this pinch here is due to the diaphragm is to dissociate the two. And if you dissociate the two, as we do during surgery, then you can determine whether this pinch here, which is no longer really here, but this pinch that you see here can often be actually some remnant of the crural fibers. I'm sorry, not the crural fibers, the angle of His sling fibers, creating a pinch here, so that the end of the tubular esophagus, defined also by the presence of submucosal glands in the angle of His, the end of the tube is right here, and these rugal folds represent a dilated distal esophagus. And here's a video of this. This looks like a patient who has a hiatal hernia with rugal folds above the diaphragmatic pinch, but I'm doing this after I've done the full hiatal dissection. So I'm going down to the end of the tube and pulling back, and it tells me that this pinch is the remnant sling fibers, and that all of these rugal folds are above the end of the esophagus and above the angle of His. And this is kind of what I see intraoperatively when I go down. I'm sorry I don't have a superimposed picture of the two, but it helps me know where the angle of His is. So I actually did this intraoperative endoscopy on about 1,400 patients, both after esophageal mobilization and after placement of a lynx or doing a fundoplication. And I examined the extent of the dilated distal esophagus, and we classified it by the axial extent of the hernia. And so we classified hernias as GERD with less than a 2-centimeter hiatal hernia, or with a 2 to 5 centimeter hernia, or patients who had and plus or minus GERD, but they had a primary paraesophageal hernia or a giant hernia greater than 5 centimeters, or revisional surgery. And you can see here that almost half of the patients who had a giant hiatal hernia, almost half of them had a dilated distal esophagus. And about 30% of patients who had a 2 to 5 centimeter hernia had a dilated distal esophagus. And then we looked at the length of the dilated distal esophagus by the classification of the procedure. And in this case, about 80% of the patients who had these primary paraesophageal or giant hernias, about 80% of them had a dilated distal esophagus of 2 centimeters in length. Pretty significant. And that's generally the realm that I see is about 1 to 2 centimeters, but occasionally it's more than that. In fact, we had some that were up to 4 centimeters in length. So what's going to happen is if you have a patient who has 2 centimeters or 1 centimeters of dilated distal esophagus, depending upon whether you put a lynx in or whether you're doing a fundoplication, even a fundoplication, sometimes you'll see that as you scope a patient at the completion of surgery, you may see rugal folds above the narrowing that is the crural or pinch or the pinch of the fundoplication. And again, if you weren't informed and you looked at this 6 months later, you think this patient has a slip nissen or a slipped lynx. You might offer them reoperative surgery when they really don't need it based just on the endoscopy picture. The other places that I use endoscopy to assess the hiatal hernia repair is looking at both the hiatal closure in terms of how it's calibrated and also any kinking. So I pass the scope at the end of the procedure to look at any resistance of the scope passing through the diaphragmatic hiatus. And if I get any resistance, it implies that either I have a tight hiatus, and I do a very precise closure of the hiatus around the non-distended esophagus. And I'll talk about why I do that in a little bit, but it's different than many surgeons have been trained to do. So it's either that or it's kinking from angulation from a posterior closure that's tented the distal esophagus up anteriorly. So if I meet resistance, it helps me know what's going on and that I may encounter dysphagia afterwards. So I need to look at that before I end the case to correct it. So I also like to assess the fundoplication and make sure that it's symmetric and not twisted or kinked or erratic, or sometimes there's an additional fold of stomach that could mimic a diaphragmatic pinch and make someone think that the patient has a paraesophageal hernia when it's just an odd fold of stomach that's been pulled up and around. And there are multiple studies to show that intraoperative endoscopy is valuable in the assessment of the RAP at the time of surgery. Another use for it are patients who are referred to me, oftentimes from some distance away, who have a paraesophageal hernia, and they haven't had a preoperative endoscopy. And believe it or not, I've found masses, I've found cancer, I found pyloric stenosis, I found gastric ulcers, I found achalasia in patients who've had a paraesophageal hernia. And had I not endoscoped them at the time of surgery, I would have missed that, and they would have had problems postoperatively that could have been treated at the time instead. Then there's the acutely incarcerated paraesophageal hernia. And we know that patients who have an acutely incarcerated paraesophageal hernia, if they require emergent surgery, the mortality is about eightfold that of elective surgery. And so ideally, what we'd like to do is get them reduced at least for a few days, if not for maybe 6 to 8 weeks. And so we take them to the operating room, or your GI colleague is trying to get them reduced by an endoscopy and they can't. And about half the time when I've taken to the operating room, simply the creation of a pneumoperitoneum has given a space for the stomach to now come down into. And I can now manipulate the stomach endoscopically and get it reduced. And then I can peg it or put an NG tube in or whatever, and I can change an emergency surgery to now a semi-elective or elective surgery with a significant lower mortality. Halar myotomy. I think anyone doing halar myotomies ought to be doing intraoperative endoscopy or endoflip. And to me, the two in conjunction are best. And if I had to choose one or the other, I'd actually choose intraoperative endoscopy, because I can assess by going down whether or not I've opened up the esophagus all the way down to the very end. And it's actually probably more precise with an endoscope than it is with the endoflip device. And I can retroflex and look and see exactly how far I've gone down. That's what physicians, proceduralists doing POEM do in terms of assessing the distal extent of their POEM procedure. I do the same thing with a Heller. I also, if there's any question, I can do a leak test, and I can also assess that the fundoplication that I'm creating is symmetric and not obstructing. Again, more data to support that. Gastrectomies, salvage gastrectomies, anastomotic opening, kinking, limb viability, leak tests. These are all things that I do just like bariatric surgeons do, and I'll talk about that in a sec. And sometimes there are large intragastric submucosal tumors that are likely benign that you may not know exactly where they are. And you can do a rendezvous procedure where you do an endoscopy, perhaps snare it or whatever, but identify it endoscopically so that you can know where to make a laparoscopic gastrotomy to come in and then resect it laparoscopically. Bariatric procedures, often patients come to bariatric surgery without having had an upper endoscopy, but they have evidence of GERD, or perhaps they're getting a sleeve gastrectomy that may predispose them to GERD. If they're having a gastric bypass, this is their last chance to assess the distal pouch. So an intraoperative endoscopy is pretty time efficient for a bariatric surgeon. It can be done at the time that the patient is being prepped or whatever. So its use in bariatric procedures, I think increasingly as we're recognizing the problems that we have post-gastric procedures with GERD, I think there's going to be an increased use of it intraoperatively or preoperatively. It turns out that an endoscope is more sensitive at detecting leaks than an oral gastric tube insufflation test. And there are multiple studies that show that if you detect a leak at the time of surgery and repair it, that the leak rate goes way down. So intraoperatively, it's great in that. And at the other end, and I don't go below the belly button in my surgeries, but it is also helpful in colorectal surgery, both for locating polyps that the tattoo may not have gotten through all the way, and also for performing a leak test for the anastomosis. Sometimes I've seen unanticipated strictures. And as I mentioned before, post-hiatal repair, if the calibration of the hiatus seems snug, if there's resistance to the scope passage, then I'll often dilate at that time 18 to 20 millimeters. And that will sort of tear a little bit of the muscle fibers around the sutures before the fibrosis is set in, and may prevent me from having to go back and take out a suture laparoscopically. Occasionally, stents are needed because of findings of, say, a mesh erosion at the time of surgery. Fortunately, in 30 years of practice, I've only had that happen once, but the stenting ability to stent intraoperatively made a big difference. And then if you're in a training institute, one of the best ways to train surgical residents is while the patient's being put to sleep, put a scope down. You've got a patient that's asleep, you've got a protected airway, you've got some time to become comfortable with skills and anatomy, and you can build up your credentialing volume for that. Preoperatively, GIs are trained and experts at evaluating mucosal abnormalities, but surgeons benefit from understanding structural abnormalities. And currently, at least in my area, this isn't routinely reported by GIs. And when I've looked at a series of outside GI reports, axial height in centimeters was reported 20% of the time. Small, medium, or large, maybe 60% of the time, and 20% of the time it said simply a hiatal hernia is present. That doesn't tell me a whole lot. The degree to which the hernia reduces is important to know. If a hernia doesn't reduce, I know that I'm going to be doing a lot more mediastinal dissection. The transverse dimension of the hiatus and the Hill classification almost never reported either. I think in the last 6 months, I had 2 GIs now report the Hill classification, which is great because knowing those are very important to determining whether or not an endoluminal procedure like a TIF can be done on its own, or whether the patient is going to need a hiatal hernia repair in their anti-reflux procedure. And then the presence of a paraesophageal component helps me understand the nature of a patient's symptoms in relation to surgery. And that's variable in terms of how often it's reported in at least my local GI community. How about patients with LPR that are looking for a surgical solution? And unfortunately, this can be the bane of both GIs and surgeons. To me, laryngeal findings are really not very specific unless they're absolutely flagrant, like this patient who's almost obstructing from laryngeal edema and has a percent time of reflux of 20% total. But inlet patches are not uncommon in LPR patients. Blair Jobe reported they were present in about 15% of his LPR patients, and they may be acid secreting, and ablation of them may help with LPR type symptoms. And what happens is when you're introducing the scope bows in order for it to sort of punch through the cricopharyngeus. So it goes from about 15 to 20 centimeters once it punches through the cricopharyngeus. And it's in that first 3 centimeters or so past the cricopharyngeus that these inlet patches are. So you have to pull the scope back and look very carefully for them, especially in these LPR patients. How about patients that have had prior anti-reflux surgery and you think, gosh, I'm going to have to reoperate on them? Well, the indications typically are patients who have dysphagia, chest pain, or recurrent GERD. What are the potential findings? Well, a stricture may be able to dilate that. Kinking, probably going to need a reoperation. Hiatal stenosis may be able to dilate that. In fact, much of the time it can be dilated without needing to reoperate. A herniated fundoplication, slip fundoplication, an axial hernia or a slip fundoplication versus this dilated distal esophagus. This is a patient I scoped today. She has had a prior Nissen procedure. She has about a 5 centimeter axial component to this hernia, which helps me know that I'm going to be doing a lot of dissection to get up there, get everything mobilized. She also has on retroflex a pretty small hiatus. So the hiatal repair held up reasonably well, but not enough to prevent things from slipping back up. So I know that I'm going to be dealing with a tight hiatus and a long hernia. That helps me think about where I'm going to be when I sit down at the operating table. Postoperative use, again, sometimes you will encounter patients who do develop hiatal stenosis, and dilating them is very easy to do. Generally, we'll use steroids first before we go to the operating room or to the GI lab for a dilation. But if you see this blanching at one particular point, you can be pretty sure that you've got something that needs to be dilated. And that helps me know what the patient's dysphagia is likely due to, and also helps me know, am I going to likely need to dilate them again? Also, and I don't do esophagectomies anymore, but when I did, assessing the anastomosis for any leak or the gastric pull-through for viability. As an operating surgeon, I thought I was probably the best in terms of being able to assess the viability and the severity of tissue damage based on my knowledge of what happened at the time of surgery. And also, I found that I was probably more comfortable doing an endoscopy soon after an anastomosis because I kind of had a feeling for that tissue that I wouldn't expect a GI colleague to be familiar with or comfortable with. And then going back to this potential reoperation, 50 to 90% of fundoplication failures are due to recurrent hiatal hernias. And to be honest, that's part of why I make the repair pretty snug. We know that patients who have hiatal hernias have collagen defects, and that's why they get the hernia. We have to close the hernia pretty snugly if we want to allow for it loosening up over time. So there may be patients who will develop some stenosis that we have to deal with. But the other part of it is if they do get a recurrent hernia, they can present with chest pain, dysphagia, recurrent reflux because the fundoplication is deformed as it herniates through the hiatus. And being able to visualize that will help me understand where the patient's symptoms are coming from. The one that I'm looking at here, I would expect the patient to have some dysphagia. They might have some chest pain. Doesn't look to me like they likely have recurrent reflux. So if they tell me they got a lot of recurrent heartburn, I'm going to do a pH test before I operate on this patient so I can counsel them whether or not their heartburn is likely to be alleviated when I go to repair this recurrent hernia. And then obviously twisting of the fundoplication visible on retroflex can be very important in understanding patient symptoms. Sometimes it's a combination of a twisted and disrupted and herniated fundoplication like we see here. And then especially if you don't have interventional GIs in your neighborhood, endoscopic management of complications such as strictures, bleeding, leaks. This is all stuff that as you build up experience, you'll feel more and more comfortable doing that. And globally, I think all of this from a surgeon's point of view is important as a stepping stone to newer technologies. We've got POEM, we've got EMR and ESD for early neoplasias. We've got TIF, transoral incisionless fundoplication. We've got endobariatrics. We've got notes. These are all things that are coming up and I think are the future of a lot of foregut disease management. And so to me, there is developing a convergence of interventional GI and surgery. And this is where I think we can really collaborate to bring about the best patient care. And so I would encourage the surgeons out there listening to this to just do it. Collaborate with your GI colleagues, work with them so that they can be familiar with what you need and also comfortable with you doing endoscopy and recognizing that you can do it safely and that you're not really competing for their practice. And then get some equipment in the operating room for intraoperative, postoperative, and preoperative use. And look to the future for single-use endoscopy equipment because I think it will help get that through your capital budget in the hospital if you can't convince them to get a whole reusable setup. And I'd also invite you, if you're not already a member, to join us in the American Foregut Society, because really that's what we're about. We're about GIs and surgeons collaborating together to improve patient care in foregut disease. We started about 2.5 years ago. We have upwards of 500 members. We have a journal. We have a collaboration, kind of like a Facebook collaboration page, only it's called Doc Matter. We've got a lot of stuff going on, and we'd really love your involvement and input into it. So I'd encourage you to look us up on the web. It's just foregut.org. You can probably remember that. You just have to know how to spell foregut. But look us up and please think about joining us in our effort. So with that, I'll pause. Actually, I'll end my discussion and it's time for question and answer period.
Yes, thank you so much, Dr. Bell, for giving us that insight into the use of endoscopy in surgical decision making. We will now move into the Q&A portion of the webinar. So attendees, remember that you can submit your questions in the Q&A tool at the bottom of your screen, the little double bubble icon. We already have a few rolling in, so I'm going to start with our first. So Dr. Bell, how many EGDs did it take for you to feel comfortable driving the flexible endoscope?
I was fortunate. Actually, I had a fair bit of my training, and actually, I've maintained good friendship with the GI fellow who trained me during my residency. I would say probably 30 or so to start feeling comfortable with it. It always helped that I kind of knew how tissue felt from the other side of things surgically in terms of pressure, things like that I can put on tissues. In terms of, the hand manipulation and stuff, it didn't take me long to learn that. I will say that there are some procedures that I think require a significant extra skill. I've done some POEMs. I've decided that that's probably, I could learn how to do it, but it'd take me a lot more than just 10 or so to learn how to do it well for me. So I think there's a range in that skill set, depending on whether you're doing more diagnostic endoscopy or whether you're starting to do procedural endoscopy.
Perfect. A few more rolling in. In what setting are you performing your post-operative flexible endoscopes?
So I'm fortunate enough. I'm part of a part of a surgery center, outpatient surgery center, that has. When we formed it, we had some colorectal surgeons who do a lot of their colonoscopies. So we had enough volume between that and myself to set up a GI lab. And so we have actually 2 GI labs in our surgery center that does ortho, ENT, that kind of stuff. And that's where I do them. I do probably 4 to 10 a week. Um, and most of it is preoperative evaluation for patients that are from out of state. They need a pH test. There's no way for them to get it near where they are. And also any management of postoperative patients. And after I've been around doing this for 30 odd years, so I do have some patients. I'd like to say no patients, but I have some patients that have issues afterwards. And I would much rather, I feel a responsibility to look after my own patients, not because they're mine in the possessive sense, but because I did something reconstructive. And for me to get better, I've got to look at what I did reconstructively. If a patient is having a problem, what could I be doing better? And I wouldn't learn that if I relied on my GI colleagues to do the postoperative work, not only because most of the time I don't get a report back, but also because I wouldn't have the same feel for it as if I was doing it live. So I've always made a promise to my patients. I'm doing a reconstructive procedure on you. If you have an issue, contact me. We'll figure it out.
Okay, a couple more clinical questions. The GE junction and then a small hiatal hernia was noted on one of your slides where you said it was a dilated distal esophagus. Can you clarify?
So that slide I was trying to, it's a tough concept to get at unless you do the endoscopy intraoperatively. But basically, if the slide didn't make sense to you, just forget it. The idea is that if you put a scope down and if you put an endoscope down and you see rugal folds, you'll typically see a pinch after that. And if the patient is in the GI lab, you're going to assume that that pinch is from the diaphragm. That distance of the rugal folds is the length of the hiatal hernia. Now, if you take the patient to the operating room, you circumferentially isolate the esophagus by dividing the phrenoesophageal membrane so there can't be a diaphragmatic pinch. And you put the scope down and you see start of rugal folds, and 2 or 3 centimeters after that, you see a diaphragmatic pinch. You know it can't be a diaphragmatic pinch, and that's the end of the esophagus. So that 2 centimeters of rugal folds is actually a dilated distal esophagus, not herniated stomach. And that pinch that you see at the bottom, that slight narrowing, is because there are the sling fibers that create the angle of His. Those gastric sling fibers still have some ability to imbricate and pinch the distal esophagus. Maybe that's the best way to describe it to you if that picture didn't make sense.
Are you using Bravo exclusively prior to reoperation for heartburn symptoms?
I gather exclusively means maybe as opposed to impedance pH testing. Um, by and large, so having had reflux myself and having had an impedance pH test and a Bravo, Bravo is much better tolerated by the majority of patients. And so it also gives me a longer time frame. So I think greater sensitivity. I think the impedance pH test is helpful. One, from the impedance point of view in evaluating a patient from a GI medical management point of view, in terms of a transnasal catheter, but it's not as sensitive to reflux as a Bravo is. So depending on the anatomy, if I feel like I need to evaluate a patient, if patients had a previousness and they have a big hiatal hernia and visually a disrupted fundoplication, I'm probably not going to get a pH test of any type on them. But if I do a pH test, most of the time I've been doing Bravos.
Perfect. Any specific diagnostic strategy for LPR?
Um, you know, it's a good question. There has been a lot written about proximal reflux measuring proximal extent of impedance or a proximal pH probe or even a hypopharyngeal pH probe, and even the Restec pharyngeal pH monitor. Globally, my experience is, and I tell patients, is pretty simple. Let's quantitate how much reflux you have. The more reflux you have, the greater the likelihood that reflux is part of the issue. So if you've got a Demeester of 60 or you've got 20% reflux time, that's a greater likelihood that your LPR symptoms are related to reflux and will get better with an anti-reflux procedure. And if you've got a Demeester that is 15, normal being 14.72, or you've got maybe 5% acid exposure, normal being, say, 4.8%. So to me, it's not totally linear, but it's a good way for me to predict that. And it comes about a little bit by some data from Mike Fahezi that the size of the hiatal hernia correlated with response of LPR symptoms to surgery. Size of a hiatal hernia tends to correlate with the amount of reflux going on. So you can kind of put the two together. So that's globally my approach. And that has enabled me also to kind of, I never tell a patient they don't have LPR. I tell them, I don't think surgery is going to help you, because they're going to go back to their ENT and the ENT is going to say, you have LPR. And I don't want to get into that battle. So my goal is to say, I don't think you have anything that surgery is going to help you with. Anna, you there?
Yes, yes. I was pulling up the long list of questions.
Okay.
Okay, we got a few more.
Sure.
What does your equipment setup look like in your hospital versus your ASC? Like leased, owned, what kind of
Oh,
brand do you
yeah,
use?
sure. So in actually both the hospital and the ASC, it's a long-term lease with a maintenance contract in it. And I know that because when the GI lab at our hospital got the new equipment, we got the old equipment that was on lease. uh, yes, but it's a lease arrangement that both settings has, and it always includes, and probably a significant part of the cost is actually the maintenance part of it.
We have another clinical question that came in twice, actually. So must be a good one. How are you eradicating the inlet patch in patients with LPR?
There are a couple of ways to do it. I've done it both with argon plasma coagulation and also with the small flexible paddle that goes through the scope with the BarX device. I don't know that one's any better than the other. Typically, we scope patients 6 months or a year afterwards, and if there's any residual, we'll ablate it. But either of those two methods has been pretty effective for us. Generally, they're pretty small areas, and so the key is actually getting the angulation on the scope to ablate what you need to. And I found both of those methods pretty good.
So shifting gears a little bit to kind of technological advancements, how do you see foregut surgery evolving in the next 5 years?
I think it's actually at a pretty exciting point, Hannah. Not only do we have some really incredible interventional GI endoscopists who are doing things in what we're now calling the third space that just amaze me. And I think that technology, part of it is that those procedures are driving new technology, even as simple as cautery cutting devices for doing poems and better ways to tunnel submucosally on the simplest side to what I would call robotic notes. People tried to do natural orifice transluminal endoscopic surgery like a natural orifice endoscopic cholecystectomy at a time when the technology wasn't there. Now we have some robotic devices that are kind of robotic endoscopes with mother-daughter extenuations and stuff. And I think we're going to start seeing, perhaps revisiting that whole idea of notes from a transoral point of view or transanal point of view. It'll be a few years down the road, but I think that's the kind of the far vision that I have for it. And with that robotic stability, it will greatly increase the number of proceduralists who can do those procedures, because one of the difficulties with doing flexible endoscopy in an invasive way is the ability to manipulate the scope, keep it stable as you're moving your hands up here and so forth. So that stability of the robotic platform, I think, is going to significantly increase the ease with which we can do these advanced procedures.
That's very interesting to see notes coming back on the horizon. In
Yeah.
in that vein, how do you think industry should be innovating to support either that movement or in other ways that you think will improve patient care in this disease space?
Yeah. Well, in foregut, there are a lot of innovations that have been going on, both in terms of diagnostics related to Barrett's, from ways to screen for Barrett's better with sort of a pill that you swallow. So looking at different ways to get a better handle on precancerous esophageal disorders, because that's an ever increasing cancer in the US and elsewhere in the world. So those technologies are evolving, and people are getting really innovative in terms of what they can do with cameras and so forth in that realm. I think the other part is happening in laparoscopy, and we're seeing, I think, an increasing movement towards robotics in foregut surgery. And as that technology evolves, I think we'll start seeing some other safety aspects to it, some training modules that will increase learning skills, and probably eventually some degree of automation in what's being done. So those are all things that I think are happening already. And I think that simply the huge advances that we've made in optics have really created a world where, I'm amazed at the magnification that I get during an endoscopy in terms of how closely I can look at tissues. It's almost a microscope. That wasn't possible 10, 15 years ago, and it's going to get even better as we get 4K systems and so forth. So these are all things that are already in process, and I think they're really great things that are utilizing technology to help us provide better patient care with the tools that we have.
Great. And one last question, I think, on the American Foregut Society. You spoke a little bit about the broad mission of collaboration. Can you elaborate a little bit about the activities going on to support that mission?
Yeah, thanks, Hannah. Yeah, so we created the Foregut Society, recognizing that there was a history, not so much of turf wars as different points of view, and so almost antithetical approaches to management of foregut disease, with surgery thinking that it was always the best, and medicine thinking that surgery was always the worst, and medicine was really the safest way to go. And I think we realized that that just couldn't be the best way to have patient care evolving. And so a group of us got together and sort of said, how can we form a collaborative society? And so we reached out to gastroenterologists and surgeons that we knew were kind of on the forefront of thinking that way, and put together a society with our mission of really being sort of multidisciplinary and collaborative effort, initially starting out with GIs and surgeons, but broadening our role to include some pulmonologists and ENTs, to try to both pursue excellence in this by, I guess I'd say, eventually setting up some standards by which we can measure our outcomes, promote expertise in this, because a lot of what we do is indeed reconstructive. And you really need to do it often to get good at it. And so we really think that foregut is evolving into a specialty. And as a specialty, it shouldn't be just a surgical specialty or a GI specialty. It really, with that convergence in technologies with endoscopy, we really thought that it needed to be a combined society. So with that, we've got um, a number of different things afoot, including ongoing education, great collaboration with Endoscopy Now, and also putting on some webinars of our own and an annual meeting um, that I think is really a strong point of what we have to offer in terms of experts throughout the country and some from throughout the world, talking about foregut disease in a very sort of compact, refined fashion. Um, the journal I just started with some great invited articles, and I think it will pretty soon find its way into the mainstream as sort of the focus for where you can find out what's new in foregut disease. Um, we're developing actually a quality initiative for the surgeons out there who are familiar with the American Hernia Society Quality Initiative. We'd really like to find a way for surgeons initially, and then going down the road, proceduralists, and broaden it out beyond that, but surgeons initially to track their outcomes and be able to compare them to, I guess I'd say, standards. Uh, and so we're looking at ways to track long-term outcomes of anti-reflux procedure and Heller myotomies and so forth. So these are all things that we think are incredibly important. And again, our goal is to promote better patient care, because I think in the past we've been too antagonistic about it and not done the best by our patients.
And with that, I think that's our last question of the day, and we are actually running right on time. So this concludes today's presentation. Thank you so much, Dr. Bell. That was wonderful, and it's great to hear the mission behind AFS as well. Thank you, everyone, for joining us, and thanks again, Dr. Bell.
Thank you very much, Hannah. Thank all of you who's spent some time listening to this and taking part in it. Take care now.